Good morning, fellows, trainees, distinguished international visitors, ladies, gentlemen. For those of you that are furiously Googling Michael Beckmann into your phones to see who he is, I can assure you he is not the current artistic director at the Ipswich Art Gallery, which is the first thing that came up when I tried it. He is, however, the Director of Obstetrics and Gynaecology at the Mater Mothers Hospital here in Brisbane, which is the Southern Hemisphere's largest maternity hospital. He's also something of a rock star in the field of evidence-based obstetrics, and I'm sure we'll all be a hell of a lot smarter this morning for having heard him speak. Please join me in welcoming Dr. Beckmann to the stage.
Thanks, Vinny, and thank you for the opportunity to speak this morning and to share with you our experience of the fetal pillow at full dilatation. The deeply engaged fetal head would occur in approximately 1 to 2% of caesarean sections. It's associated with adverse maternal outcomes in terms of maternal trauma, uterine angle extensions, excessive bleeding, blood transfusions, prolonged hospital admission, and adverse neonatal outcomes in terms of fetal trauma, particularly fetal trauma to the baby's head, skull fracture and fetal death. It's one of the most frightening of all clinical scenarios for those who practice obstetrics. One of those moments where you wish the ground would open up. For registrars in particular, learning to perform a caesarean section, it is not the technical skills of tying a knot. It's not exteriorising the uterus or putting it back. It's actually the scary bit of what if I can't deliver the baby's head. Indeed, it's been the career-ending moment for several registrars, at least in this state. So, delivery of the fetus at caesarean section is sometimes tricky, and with no disrespect to our college, there are very few guidelines or position statements that exist on our website, but there is actually one about delivery of the fetus at caesarean section. The guideline provides a description of the challenging scenarios. It provides some broad, non-specific advice about what one can do. But this is an evidence-free zone. The typical scenario is that we try and deliver a fetal head with one hand, and then we try harder, and then we use the other hand and try even harder. Moments pass, then we remember it's time to take a breath. We might look around the room and see if someone can catch our eye, and the junior midwife in the corner looks at us and we ask her to put on a pair of gloves. She does so, but doesn't know what exactly you mean by put on a pair of gloves. The drapes are lifted. You ask her to push up without any direction. She pushes, you pull, you pray, and usually the baby comes out. It's a terrible event, and there must be a better way. The fetal pillow is a device, and one of only a few that have been on the market that provide an alternative option. The fetal pillow, I think you saw the videos playing before we came in. The fetal pillow is a simple device with a flat platform which sits against the pelvic floor, inserted vaginally prior to delivery of the fetal head at a caesarean section when you think you'll have difficulties. When inflated with 3 syringes worth, it lifts the fetal head and makes what should be a difficult delivery a little easier. Some of the first reports of the fetal pillow were indeed at the World Congress in Kuching a couple of years ago, which I attended. I made contact with the company and assisted the TGA process to have a fetal pillow in Australia, and the Mater started using a fetal pillow. We're particularly sensitive to that. In our organisation, we've had 2 fetal deaths due to difficulty delivering the fetal head at caesarean section. Those babies died as a result of skull fractures, and we're keen that we might have an alternative. So, I'm here to report the initial Australian experience with the use of the fetal pillow. And what I have to share with you is a retrospective cohort study, and what I have in the data here is women who underwent a caesarean section at full dilatation over almost 2 years at Mater Mothers Hospital in South Brisbane. We collect a lot of routinely collected information, and for at least 5 years have been recording information about how we deliver a baby's head at caesarean section, whether the head has been disengaged by the surgeon from the abdomen, or whether there has been a push method from below by an assistant. And therefore, when the fetal pillow became available, we added this question to our database and therefore have the prospective collection of data here that tells us in each of these scenarios of where we have been delivering a baby at full dilatation, whether a hand push method was used, whether the fetal pillow method was used. And so I'm able to share with you the maternal and neonatal outcomes comparing those two groups. So over this period of time, we've performed 361 caesarean sections at full dilatation, and we've used the fetal pillow method as of a couple of weeks ago in 91 cases, and a hand push method in 69 cases. Comparing the two groups, you can see that they are reasonably similar in terms of parity, age, BMI, gestation. We would commonly in our organisation use a fetal pillow because there has been difficulty delivering the fetal head following an instrumental birth, and the failed instrumental rate that preceded the use of a fetal pillow or the hand push method was the same in both groups. And about half the time, we were using the fetal pillow in a Category 1 scenario. What do we find? So mindful that we're looking at observational data, and we're looking retrospectively at one group versus the other. So we noted that there was a trend towards lower APGARs at 5 minutes in the hand push method, and a trend towards more babies being intubated and admitted to the nursery. We observed a difference in the cord arterial pH in the hand push method being lower than the fetal pillow. That we measured a mean blood loss, which was less in the fetal pillow group. No difference in blood transfusion. A trend towards decreased angle extensions in the fetal pillow group, and a surprising 20 hours difference in postpartum length of stay. So as I reiterate, this is observational data, and it's not going to suggest that there's a cause and effect relationship here. It would be quite reasonable to conclude that this is case selection, that we've been less likely to use a fetal pillow in scenarios where there is more urgent fetal distress, and hence that's why we're observing some of those neonatal outcomes. However, these initial findings do confirm others' experiences that this is a device that can assist in this scenario. We found it to be an effective aid when delivering a deeply impacted fetal head, and certainly larger numbers are needed to confirm what I have shared with you today. But the clinician feedback is universally positive. And of those almost 100 fetal pillows that we've used over half of them in the last 9 months. So as we are familiar with this device, we become used to using it. It's become part of what we do and part of a strategy of overall minimisation of harm. So within a culture of trying to have no harm, this is a very important strategy. It's relatively inexpensive. It's easy to train, easy to insert. There's no known harm with the device. And in the absence of any other effective strategy to deliver a deeply impacted head at caesarean section, I would suggest that this is a helpful device to have in your box of tricks. Thank you. Does anyone have any questions? Hello. The incidence of failed fetal pillow. Do you mean the incidence of being unable to insert the pillow into the vagina? No, we've never had to revert to a reverse breech. I'm using routinely collected data to show you what the outcomes are afterwards. So I don't have to share with you the individual outcomes of each delivery and how easy or difficult that was. But I know that our experience is that even in the scenario that you thought was going to be the absolute worst, it was surprisingly easy to deliver the fetal head. So particularly people using it for the first time would be choosing commonly, I've just had a vacuum extraction that's not been successful, the consultants come in and apply a forceps because I think I can get that out, and now you've got a very jammed in head and a need to deliver a baby, a very challenging scenario, and a surprisingly easy delivery as the fetal head is elevated. I think that the papers that have measured this have elevated the fetal head, if I'm not mistaken, by 3 centimetres, a station of 3 from where you started from. So we've had in our experience, no failures, as you put it. Okay.
Well, there'll be some time for some further questions just at the conclusion, I think. I might call Mr. Ramesh Ganapathy as well to the stage. He's a consultant MFM specialist at Epsom and St Heliers University Hospitals in London, and he conducted some studies looking at the use of the fetal pillow whilst working at the City Hospital in Birmingham. Please, Mr. Ganapathy.
Good morning, everyone. Thank you for this opportunity. We are presenting the data for 57 of our cases. We've used almost the identical number as Michael said. We have around data for 114. We've analyzed 57 of them. I'm not going to bore you with all the statistics. I'm just going to tell you what we did and what we found. So the hospital's a very busy inner-city hospital in Birmingham. It has 5,800 deliveries with a section rate of around 24-26%, with an instrumental rate of around 8 to 10%. We do have a 3-tier system of trainees or residents, 8 obstetric consultants on site for 12 hours. We've just gone up to 16 now. Everyone knows this. I'm not going to dwell on this slide for too long. Difficulty in delivery of the head, increased HDU admissions. When you're trying to speak to the business people, when you talk to them about HDU admissions and neonatal morbidity, they suddenly sit up and listen to you. So this was the background from where UK is at present. Almost half the patients are going to have complications. 1 in 10 is going to have a uterine extension. 1 in 20 will have a cervical or vaginal tear, and almost half of them are going to have a postpartum hemorrhage of greater than 1,000 mils. Although our data is not as dramatic as this, but because there's a very large data set, we have to accept that that might possibly be true in the larger part of the world as well. So the way it works is we decided, unlike Michael, where they compared to, we decided that every second stage section will have a fetal pillow, because we had enough data from the year before of the complication rate, and we said we're going to use fetal pillow in every case. And this came about as a knee-jerk reaction because we had a registrar who was unable to get a baby out in a neighboring hospital and called the consultant in, and the consultant struggled for 10 more minutes, and the baby died. It was a first pregnancy, low risk, no complications, and the registrar gave up obstetrics just 1 year before becoming a consultant. So we used the video. It's very straightforward to use. And we had a rotating system of training people every 4 weeks because we do have a large amount of locum staff as well. And the starting point was training the theatre staff, because the theatre staff would prompt everyone saying, if it's a second stage section, why aren't you using a fetal pillow? So when the prompt came from them, everyone used a fetal pillow. Simple pie chart, failure to progress was the vast majority of cases. 1 in 6 were due to a category 1 cesarean section, and the rest were due to a failed instrumental. Our patients, as you can see, it's UK, so the proportion of obese people is quite large. But in our hospital, we don't even blink till you hit a BMI of 40. So what did we find? Our tag extension rate prior to use was 10%. We got down to 5%. Vaginal lacerations, none. and the postpartum hemorrhage, which we classified as 1.5 mils, which was the trigger for the massive obstetric hemorrhage to drop from 20 to 5%. This was what was interesting for us. We do have a high dependency unit on labor ward, and the use of that 1:1 care dropped from 10 to 3%. Transfusion rates, initially it is quite high because the population we serve has a lot of pre-existing anemia. So if they did bleed, the risk that they would require blood transfusion was quite high to begin with, and then it dropped 1/3. We haven't done the stats for the p-value yet because we're just waiting to finish 100. This is where it gets interesting, because as a single unit, people talk about the cost. The average duration of stay in a hospital in the UK without staff charges is around £450. So it's more expensive to stay in a hospital than in a central London 5-star hotel. But by the moment they move to an HDU, it just jumps. You might as well move to the Waldorf Astoria in New York. So by the time you reduce the number of days from 5 to 2.7, it pays itself, and you actually make a profit, if you can call that a profit. Although the device is marketed as reducing the incidence of HIE, you will never be able to prove that unless you have multiple centers in the world getting their data together. Fortunately, the incidence of HIE is quite low. We will never be able to prove as a single center statistically that it reduces the incidence. We had 2 cases of neonatal admission, but they were for observation because the mother had pre-existing choriamnitis. And we did look at infection rates because it is a device being used at cesarean section. And there was just 2 cases with superficial wound infection, the incidence of which universally is around 5%. So going back sort of the question that was asked before, who reported was it difficult after you used the fetal pillow? 2 of the cases, they were unfamiliar with the technique, so they just felt like a Foley's catheter. I put some in, but the device works only if it's inflated appropriately. And this will happen in any place when you start using the device for the first time. You have to be quite diligent and quite strict about the amount of saline that's used. Once you do that, almost universally, I take the opinion of the juniors and the registrars rather than consultants, have said that it was almost like doing a planned elective section in terms of the position of the fetal head when they entered inside. And we paid top dollar, so there are no conflicts of interest here.